First up will be Dr. Salil Deshpande. He is a medical doctor and he is the Chief Medical Officer for the United Healthcare Medicaid plans across the state of Texas. Speaking after Dr. Deshpande will be Dr. Minnie Kalon, who is with the UT Dell Medical School and just a jack of all trades and one of the most inventive people I know. Following on her heels will be Nirav Shah, who is with Social Finance, which is a fascinating organization that looks at different ways of financing social interventions. And then last, we'll hear from Dr. Len Nichols, recently retired from George Mason University and now with the Urban Institute. And the questions we're going to be asking you to focus on and think about when you're preparing your own questions for the panelists are: what are the major challenges to funding this kind of work? And what approaches are being used or proposed in Texas, in other states, or nationally? And with that, let's move off the shared screen, Eileen, and into panel view. And I will ask Dr. Deshpande to kick it off.
All right, thank you, Elena. And thank you to the Texas Health Improvement Network for including me in the conversation this week. As you've heard, I'm Salil Deshpande. I'm the Chief Medical Officer of United Healthcare's Community Plan of Texas. It's a managed care organization that represents United Healthcare's Medicaid business throughout the state, and we've got extensive experience among the STAR, CHIP, STAR Kids, and STAR Plus Medicaid members in Texas. We represent a cross-section of healthy pregnant women, children with chronic conditions, and children with special healthcare needs, the disabled and the elderly, many of whom have behavioral health comorbidities or are nursing facility eligible. Today, I'm happy to share with you a little bit about one of United Healthcare's longstanding and still ongoing projects in this space of addressing social needs through healthcare. So that we're all grounded, I'll provide some background on the project itself, and then I'll hone in on the challenges with funding this initiative in particular, and these kinds of social initiatives in general. So in the spring of 2016, our health plan began a partnership with the Green and Healthy Homes Initiative, also known as GHHI. This Baltimore-based 501c3 nonprofit got its start in 1986 in the childhood lead poisoning space. Today, GHHI sees its mission as breaking the link between unhealthy housing and unhealthy families by creating and advocating for healthy, safe, and energy efficient homes. In Maryland, GHHI provides a direct service program where they perform home assessments, education, and direct remediation of environmental health hazards to low-income families. Outside of Maryland, GHHI essentially serves as a consultant, providing technical assistance and program management to stakeholders throughout the country around healthy homes and environmental health issues. So United Healthcare's initial collaboration with GHHI focused around a Robert Wood Johnson funded pilot in Texas that was essentially an actuarial analysis only. They were looking at whether it would be economically feasible to scale evidence-based interventions for patients with asthma. And I'll get back to this point in a moment. Now, the evidence-based intervention that we're studying comes in two parts. The first part is a clinical intervention for patients with asthma, and there's a social service intervention, which is the second part, the social service intervention for these patients and their families. So going back to the first part, the clinical intervention itself is comprised of patient education on asthma, as you might imagine, and it also includes a comprehensive environmental health education. the clinical intervention also includes a detailed home environmental assessment. So that's the clinical intervention. The second piece of this is the social service intervention, which entails active remediation of adverse environmental factors in the home. So adverse with respect to that clinical condition of asthma. So adverse environmental conditions, this means mattress and pillow cover installation, it means removal and cleaning of carpets, mold remediation, air conditioner installation, furnace filter replacement, venting the kitchen, the bathroom, the dryers, and so on. So I mentioned a moment ago, we were studying economic feasibility. So in this case, the clinical and social service intervention is intended to reduce unnecessary or preventable healthcare utilization for patients with asthma. The reduced healthcare utilization is then calculated as savings, which would be used to repay private investors. So why are we talking about private investors in this conversation about healthcare for asthma and environmental home remediation? I'll come back to this, but let me give you a quick update on where UHC is with this particular project right now. We're moving forward on a second phase of the collaboration. Remember that first phase was just actuarial analysis only. We're moving forward on a second phase with local providers, Baylor College of Medicine and Gerling Home Health, in order to actually develop working relationships between these different providers in our local community, and in order to serve our United Healthcare Medicaid members who are the most impacted by asthma and have significant issues with preventable utilization. So Baylor's Environmental Health Service Department will perform the clinical intervention, and Gerling and its subcontractors will perform the home remediation. We've been fine-tuning processes for member identification and outreach, for handoffs and communication between partners. We've been working through the contracting challenges, operational details, data security issues, and now with COVID-19, we're working through how we can implement telehealth in this space as well. But let's get back to the funding for this initiative. There's a growing body of evidence behind the effectiveness of home environmental remediation for children with asthma. Not to state the obvious, but there is no healthcare funding available through Medicaid or through any other payer, healthcare payer for that matter, for cleaning carpets or for mold remediation. And this is where the private investor comes in. We're having to look for private investors to fund these social service interventions for individual members. Interventions that are frankly relatively low cost, yet have a known favorable impact on health and on healthcare utilization. So for now, for the purposes of testing our pilot collaboration with Baylor and Gerling to serve our Medicaid members in Texas, United Healthcare has made the decision to serve as that private investor. I want to emphasize that this project is focused on specific Medicaid individuals in our population and in improving their asthma. There's a defined condition for whose healthcare utilization we can track and where we can attribute the savings. And when my organization can directly identify these healthcare savings, and when they can see that these savings exceed the cost of the otherwise unreimbursed home remediation expenses, it becomes just a little bit easier to justify our spending on these social interventions, in addition to the healthcare services that we're accustomed to paying for. So for this pilot focusing on patients with asthma, UHC has volunteered to serve as the private investor for the home environmental remediation. United Healthcare has previously reached out to Texas Medicaid to discuss filing a CMS waiver for inclusion of home remediation as benefits under the Texas Medicaid program. And leaders at CMS have informally indicated their support for the concept. Philanthropic dollars aren't necessarily suited and frankly aren't available for scaling social interventions like this across large populations in consistent and longitudinal ways. Private investment through a pay-for-success model is a possible approach. Direct and quantifiable healthcare economic savings can justify that social service expenditure. I'll conclude my comments here by asking, But what about addressing social drivers for patients who don't have asthma? This clearly visible connection between a specific clinical condition, addressing a social issue, and then measurable healthcare outcome isn't always easily derived. I'll turn it back over to you, Elena.
Thanks very much. You set everybody else up, and I know they will have questions for you, even if the audience doesn't. Let's move on to Minnie and tell us the kinds of programs you're up to.
Great, thank you. And it's great to follow Salil for many reasons, one of which is that one of the things that I will share with you is that for the change that we try to create, partners like Salil, and now I'm not just talking about United Healthcare and United Healthcare's Medicaid programs in Texas, but leaders within those payer organizations who have two features, both of which we really enjoy with Salil in our program. One of which is really, of course, invested in the change that we're here to talk about. And the second is brutally frank and direct when he thinks things are not going to work within his organization. And you need both. You don't want just someone saying no, and you don't want just someone saying yes. You want the approach to be, that's the direction we have to go, but I'm going to tell you straight up if that's just not going to cut it for the way in which our business works today. So thank you, Salil, and what a great setup. So where we step in is the program that I lead called Factor Health is a program and a platform. And what we've asked is, what if you imagine addressing individual health? So this is all in the space of individual people's health. But what if we thought about addressing health conditions first by not even considering traditional clinical care? I don't mean without expertise. I mean with the best possible clinical expertise. But what if is an exercise? Even, Salil, as I was listening to you and thinking about what you call clinical, right? You call the environmental assessment of the home clinical, which means certain kinds of people within certain healthcare institutions are doing it. And so sort of our take on it would be just, let's say, well, who is actually needed for an environmental assessment, right? Who is actually needed for these functions? And let's first try to find them outside of traditional healthcare. And then only when necessary, let's reach back into healthcare to draw the connections that we need. So that's the frame that we come into this with. And the reason, and there are many reasons, one of which is the people that we are trying to serve would prefer to be served in their real lives, and real lives are actually quite dissociated from healthcare. The example programs that I will share are, for example, for older adults, mostly socially isolated in their homes. And as we joke at the medical school, most of my colleagues, as wonderful as they are, just don't have that's not their skill set or their experience to know what it takes to knock on someone's door, to present a persona that is immediately warming, to be empathetic and just ask questions and draw people out to really understand their needs. That's just not the core framework for what, how we are trained in medicine. So we start outside and reach back inside. But like Salil said, and we come together in this, the goal is to focus on specific populations and specific conditions, because for us, the space of the problem, and you'll hear people take different parts of the space, there's sort of the upstream structural interventions. And I think that when you're going to hear from Nirav and Len, you're going to hear about different kinds of payers, not just multiple payers, but from different sectors that are necessary as you get to sort of a community level and think about these large structural adjustments. The place that we come in is what is the midstream care. It's a little bit like the midstream in the diagram and a little different, where we look at people with chronic conditions and ask, are there better ways to provide them better health outside of the clinic where we can get results in short periods of time? And short periods of time for us is less than 2 years. And the reason we have the less than 2 years is because we want to make sure that when we're talking to someone like Salil, he doesn't just nod and say, that's fascinating, let's talk about it next year. He goes, oh, okay, if you can actually get a certain result in less than 2 years, that's actually relevant to the time frame that Medicaid uses, for example. So I don't know the answer, but let's talk. And that's our main goal, is to get the payers to a place where they go, let's talk. And let's talk about what? So the next question on the table is, what kinds of outcomes are payers willing to pay for, and willing as a combination of the payment approach and interest of the payer, as well as, of course, the policy environment that allows them to be able to pay for some things, as again Salil mentioned. So what are the outcomes? What scale of outcomes and results would really make them sit up and go, well, actually, yes, if you could take this very diabetic population that's very hard to reach, and we know, inappropriately utilizes the emergency room. Yeah, if you can get a pretty large scale of a result, we'll talk, because that would really mean something to us. So we work with the payers first to understand what those populations are and what degree of impact would really make them put in a little bit extra effort to come together with us to find a way to pay for those results. So that's a starting point. But then the next question is, can we get those outcomes? And so then we focus on that as well, because you can't just take one or the other. And for that, there are two things. One is, what is the evidence to date? And I will share, and we can follow up in conversation. We have a lot of evidence to suggest that specific interventions can work, and yet most of it is incomplete. So when you really dig in to understand, well, what do we know about an intervention? Let's take food, for example, which is, honestly, the Commonwealth Foundation has a wonderful grid of sort of the best cost effectiveness work that's been done. And if you look at the top of the list is food, right? The impact of nutritious food, food delivery, and then also medically tailored meals. It's sort of got the best level of evidence to say, if you have an intervention that focuses on those, you're likely to be cost effective per some analysis, and here are all the references. And yet, when you look at this best evidence, what you see is, and for example, the papers and the research that we use to anchor our food-related work are retrospective analyses. They're not interventions that have been tested in any kind of a trial. And I don't mean, that we have to go to a gold standard of a randomized trial because that's some official gold standard. I just mean where we have some confidence that the things we did were the things that created improvement in health. And so it's a beautiful study, for example, that Berkowitz and all have done in Massachusetts, really great results that give us some numbers about how cost-effective things can be, but it is a retrospective data analysis that gives us those answers. And the few interventional studies are very small numbers. And for example, in the work that we are doing with United Healthcare, with Meals on Wheels Texas here in Austin, the scale and scope of the program that we have is to look at what kind of effects we can have on diabetics, significant diabetics, with their impact on A1C levels, and can we get a large enough impact to make Salil pay attention? And I'll tell you that even for that, there is no prior evidence to suggest how many meals a week that are diabetic friendly does it take to get enough of a management of A1C levels, let alone the fact that actually improving A1C levels gets us only partially there when we talk with United about what actually makes them think about costs and expenditures, because they're really looking at, well, hospital utilization, which is yet another step removed. So we look at the evidence, we're very critical, but we're also very hopeful, and so we're creative. We don't just stop when we see something doesn't work. We've learned how to look at systematic reviews to understand that systematic reviews are useful for some things, but actually average results are not useful if you're trying to really improve programs. So if you have to believe systematic reviews, there's no ability to change weight and obesity for youth, and yet we believe there are some specific examples of work that have been done that are very impactful. So how do you find the work that you build on? And then similarly, we look for providers. Who are the people on the ground that have the strength to be able to deliver this work? And you need both, because in the end, DelMed is not going to be the one that has a full-fledged program that delivers medically tailored meals and social connection to our older adults at home. So we systematically look for the strong providers on the ground, bring those together, and then work on program design. And that's the final piece I'll leave you with, is that program design and the ability to scale are also complicated. And it's not the case that just because Meals on Wheels produces, does really good work. They do. And our other partners, we're looking at partners in Dallas with a slightly different tilt. VNA Meals on Wheels do really good work. And yet it is clear when you dig in that they've got a ways to go for those programs to become really fine-tuned programs that can produce replicable results that then could scale and get paid for. So I think with that, I will pause. That gives you a sense of the various pieces we work on, almost all at the same time. But the reason we do that is because we believe that if you don't address all these pieces all together, we're not going to be able to really come up with powerful programs. Even then, I believe that we have a portfolio. We have programs in Austin, Houston, and now looking at Dallas as well, that some of those are going to work and some of those are not going to work. And so we're looking at really maximizing the chance that we can prove results, outcomes worth paying for over a couple of years with our various payer partners, which are currently mostly Medicaid MCOs. Thank you.
Thanks very much. Nirav, take it away.
Perfect. Thank you, Elena, and thank you for allowing me to be part of this dialogue. So I'll have to say, I'm not sure I'm credentialed. I don't have a PhD or MD next to my name, so we'll see if I can meet the mustard of my esteemed colleagues here. I like the way Elena teed this up in the sense that this is where the rubber meets the road. I work for an organization called Social Finance. We're a nonprofit organization and we're relentlessly focused on action. And so this group gives me energy and appreciation. And as a nonprofit, our mechanism for driving action is called Pay for Success. And when people typically think about Pay for Success, financing model, and financing is a thought that quickly emerges into individual and people's minds and conversations that I'm having. And certainly financing is a component of Pay for Success, but not everything that Pay for Success does. So I thought it'd be helpful to start this conversation and just stepping back and widening the aperture on Pay for Success, because we think about Pay for Success as a collection of principles, specifically 4 principles. The first one is, how do we focus on outcomes? Both Salil and Minnie talked about this. Much too often, our funding is focused on number of people served, which scale is important, but scale without effectiveness is not helpful, and it's a waste of resources, to be quite candid. And so how do we shift the conversation to really hone in on the outcomes that we care to achieve for individuals and communities? The second is, how do we use data and information to inform what kind of investments we are making, but then also use data and information to make sure that we are managing how operations are going over time. The third principle is tying payments to performance. Again, most time payments are given out with the promise of something being achieved, and most often than not, that outcome is actually not even measured to understand if the dollars were hit the intended outcomes or the objectives. And the last is, how do we apply strong governance processes to shift the mindset from compliance to performance, again, using data, real-time information to drive that decision-making. And so as a nonprofit, what we do is tie these principles, these 4 principles together to meet the needs of any local context. And there's 2 overarching goals here, which really straddles the river graphic that Elena led with. The first goal is we want to get measurable impact at the human level. So individual impact, if you translate it into the language in the river piece. The second is, how do we use that individual impact to really drive community level impact? How do we inform where resources are spent, how much resources are spent, and what's the right allocation of those resources? What are policies that should be put in place? And the third piece that's sometimes often neglected that both Minnie and Salil spoke about is, what are the infrastructure investments that need to be made in a community in order to get to the next level of impact, which sometimes are overlooked. And so at times, the Pay for Success strategy has private investment that comes in to help amplify it. And at times it doesn't. And we work along that full spectrum. I want to spend a couple minutes making this more concrete for folks. And we're doing a number of initiatives, 3 to be specific, around the country for individuals experiencing homelessness, and using Pay for Success to advance and accelerate both outcomes for individuals, but how do we set up systems that can eradicate this challenge over time? And for folks that might be familiar with programming and services for individuals experiencing homelessness, specifically chronic homelessness, there is a very large and strong evidence base around permanent supportive housing, which is a model that's being employed in all the three examples. And so the evidence is clear and quite loud that the program works. Now, much like many other social services, the challenge is not that we don't have the evidence. The challenge is how can we scale that evidence effectively? And so the focus of the Pay for Success project, one, is ensuring effectiveness through the identification and measurement of outcomes over time. The second challenge around this specific issue around homelessness is this idea around wrong pockets. So when you look at some of the factors and challenges that's a result of individuals experiencing homelessness, clearly there's individual challenges faced for the obvious reasons. But there's also challenges and burdens put on the healthcare system. Individuals are using the ER as their primary care setting. And so there's a lot of utilization for high cost, high-end needs in the ER. Individuals are also in and out of the jail system, which is costly for the criminal justice side. They're also using a lot of emergency services, police, ambulance, emergency services, which are high cost to systems. And so to use an example, in Austin, where we're working, those three different systems are governed by many different organizations. And if you pick one organization, they don't have the vested interest, or certainly the financial interest, to go at the problem alone, because there are a lot of other beneficiaries for reducing homelessness. So a big goal for our work in Austin around Pay for Success is how do we make a bigger tent and include all the folks that have a vested interest in improving this issue, not only from an individual standpoint, from a community standpoint. And then third, it's a cost-effective way to use the dollar. And so we have gotten representation from the healthcare sector, from the city of Austin, from philanthropy and private investors, all coming together to think about how they're going to solve that, which sounds great on paper, and it is, but it also does come with some significant challenges. And the challenges are, first and foremost, mindset. The Pay for Success approach is a very different way of funding operations. Instead of government funding up front with the promise of certain outcomes, investors in this example are coming in and providing these services for permanent supportive housing, and then the city government and healthcare will pay back only if some measurable outcomes are achieved vis-a-vis housing stability and reductions in emergency utilization. So that's a very different paradigm of funding services. And so the first one is getting over that mindset shift. Second is there's challenges with contracting and budgeting that we've had to come over. I think the biggest challenge is that across all these different actors, there's a universal agreement on the top line objective, which is to improve outcomes and use our dollars more effectively. Second and third tier outcomes vary along the different organizations. And so how do we create a project that can speak to the second and third objectives of all of these organizations and align them in a way that everyone is interested in continuing to move forward with this initiative? We've been 3 years in the making in the project in Austin around individuals experiencing homelessness. We were right at the finish line and COVID happened. And so right now we are addressing the realities on the ground with the pandemic, but hoping to continue this project forward because there's a big opportunity of creating a better system with more actors that can sustain these services over the long term with the goal of eradicating homelessness. And so that's just one example with a few different challenges on how to move forward. So at that, I will pause and pass the microphone to Len, but I'm excited for the discussion.
Thanks, Nirav. Len, you're up. Are you using slides?
I'm going to try to, Elena. Let's see if this works. Can you see
There you go. It's working.
that work? Okay, let's see if I can get it full screen. Okay, great. So, well, thank you, Elena and Xiaoqi and Eileen for inviting me to join this party. You know, I am just a simple country health economist who grew up in Arkansas. I didn't know all these innovative Texans I've met today. And I'll just say that when I started this project, I was really looking upstream and sort of trying to figure out why is it so clear that there's too little investment in the social determinants of health, either upstream or midstream. It just seemed obvious. It didn't take a PhD or a rocket scientist to see we're not doing enough of that. And so I met this brilliant co-author, Lauren Taylor, whom I'll talk about in a minute. But we came up with this, what we call collaborative approach to public good investments. And I love that image, and I'll talk about a public good in a minute, but that image is one, first of all, it's free, it's not copyrighted, but second, it illustrates, I think, an extremely important point, which is why I've underlined those two words. Everybody in the community has a piece of the puzzle, and no one in the community has a whole puzzle to be able to be solved. So you've got to have collaboration. So if you remember that wonderful keynote that Laura Gottlieb gave yesterday, I'm in the space of alignment, but it melds into advocacy of developing new resources. It's all in the rubric of community-focused strategies, because I think the community is the right unit of analysis. And I could show you the math and a little bit of game theory, but it's sort of better to do pictures. And you know, who doesn't like puppies? And Lord knows we've all benefited from puppy pictures during all the confinements and stresses we've had this spring. But imagine for a moment that a family wants a puppy, and imagine the children really want a puppy, and the parents, so as you know, the mom's an economist and maybe the dad's a game theorist, and they want to have their children get a puppy, but they want the children to be responsible and learn responsibility by dealing with the puppy. So maybe they say to the children, okay, look, we will definitely consider acquiring a puppy, but you have to promise two things. You have to tell us what you're willing to pay, not only out of your savings right now to buy the puppy, but what you're willing to pay every week, because we're going to have to feed that puppy and we're going to have to take that puppy to the vet. And I want you to tell me how much time you're willing to devote every week to make sure that puppy gets played with adequately and walked, etc. And the children are somewhat different, right? The 12-year-old is about to go into junior high, and she's pretty excited about her afternoons and evenings being more filled, but she also would like a puppy. However, the 9-year-old there is very excited about a puppy, and the 6-year-old can hardly contain himself in thinking about what he'll do to the puppy. So the parents say the following, say, okay, you tell us what you're willing to contribute in money and time. And they have very different allowances and ability to earn money doing chores, and they have very different time allocations in their lives, but they go in a room separately. That's the trick. The parents make them go in a room separately, think about it hard, come back and say, now look, if you guys don't offer enough money to cover the cost or enough time to cover the week, well, then we won't get the puppy. So the whole point of our model is to take what those individual stakeholders are willing to pay to acquire the thing, the investment, the good, the puppy that will generate benefits for all of them, take what they're willing to pay and compute fair prices and thereby make it all sustainable. So there's the paper. I highly recommend in your spare time you take a look at that, and that's Lauren Taylor's a co-author. She just finished her PhD at Harvard and is on her way to NYU. And here's another way to illustrate what we're talking about. Imagine housing, food, transportation, complex case management, all the kinds of interventions that my panelists just mentioned. And that's going to benefit people, right? It's going to make them better off, going to improve their well-being. And in doing so, will likely strengthen the community in which they live. At the same time, it could very well be the case, and in particular, as many made clear, if we target the intervention correctly, right? You've got to target the intervention correctly. You could lower costs for certain stakeholders in the healthcare system, be it insurers or even hospitals, especially in a non-expansive state like Texas, where you've got so many uninsured. But you could also possibly create to what I call mission consistent value. And that would be people who benefit from it, but don't get a financial return, but they actually have a vested interest in the welfare of the people who would be benefited. So you might imagine an intervention where you focus on, say, homeless who have serious mental illness and substance use disorder, those for whom the evidence on permanent supportive housing saving money is the strongest, but also people who don't have those particular conditions, but who are also chronically homeless could benefit, and the community could benefit, and the mission-driven contributors, which could be City Hall, could be philanthropy, could be employer groups, could be lots of different places, may have a value attached to that. Now, of course, there's a time horizon issue here. Not every return is going to be quick, and some of them are going to be very long, but you can factor all that in as you do the math, as Nirav and Minnie just said. So let's talk about what CAPG does. It turns out when we look upstream and we see these issues, we see the lack of housing, we see the lack of transportation, we see the inappropriate food, we see all the things that lead to people not getting what they need. Those things are like public goods. They create what we call a free rider problem, in that no one person typically is willing to invest enough to solve the problem, because the benefit to that investment would flow to so many different potential beneficiaries, not just the people, but all those downstream actors. So it turns out the solution to this kind of free rider problem was created by a group of economists over time in the 1970s, believe it or not, a long time ago. And it works under two conditions. And those conditions are, first, there must be an operational local stakeholder coalition, a group meeting around the table like Minnie described. And there's got to be someone who can play the role of trusted broker. And a trusted broker, if you go back to our metaphor, are the parents. The children are the stakeholders. They all know they're going to benefit individually, and there's going to be a collective benefit. They know each of them will benefit in addition to themselves. And what turns out to be true, we did not know this really when we wrote the paper, when it came out in 2018, these conditions are widespread today. And they're widespread, I think, for three pretty powerful reasons. Number one, the readmissions penalties of the ACA forced hospitals for the first time in quite a long time to really pay attention upstream, because they knew people were being readmitted, not because of something the hospital did wrong, but because of what's going on in the household after their discharge. So they began to look upstream in a serious way. Number two, Medicaid expansion in the states where it happened, and of course it did happen in most of our states. Medicaid expansion put the homeless on the rolls of health plans for the first time ever. And health plans maybe didn't know a whole lot about the homeless at that time, but health plans can find out pretty quickly who's costing the money. And so they began to focus on workers and community health workers and all kinds of interventions to try to basically reduce what we're accruing to them now. And then finally, and most poignantly, the opioid crisis, because opioid led to a situation where criminal justice, family services, and emergency room docs are in the same room talking about a patient. Okay, how can we solve this patient's problem? Well, it's not a patient problem, it's a family problem. Not really a family problem, it's a neighborhood problem. Not really a neighborhood problem, it's a community problem. And so suddenly you had these coalitions all over the country looking upstream, looking for a way to solve the problem. And our paper, for whatever reason, it's a clever paper, it's not that clever. We came at the right time because we gave people a language to talk about this free rider problem and a solution that seemed to be embedded in economic logic. So the way the model works is you assemble your coalition, you agree on what issue you want to focus on, what specific intervention for which specific population. And then each stakeholder confidentially reveals to the trusted broker and to the trusted broker only what they're willing to pay, if you will, a bid to solve the problem. What are you willing to pay? The trusted broker takes everybody's bid, just like the parents did in the dog example, add up the bids. If the sum of the bids across all stakeholders exceed the cost, well, then by definition, you have an economically viable project. And the difference between the aggregate value and the cost, in a way, is a surplus that you can share and enables you to assign what we call fair prices. That means suppose the value exceeds the cost by 10%, then you only need to actually have people pay, and you assign a price that's less than the bid, less than the value. So that difference between the value, in many cases, reduced costs later, the difference in that value and what they have to pay and the price to do the project is a guaranteed ROI, which makes it sustainable. And that's what we mean by the model becomes sustainable because of enlightened self-interest. Now, we wrote a paper in August of 18 and published it in August of 18. And typically, when you publish a paper with economic content in the United States, typically, at least in my case, I get like 4 emails, right? And the first one typically says, Len, it's time to retire. And the second one says, okay, you should have used some other data set or some other mathematical proof or whatever. And this time, we got 20 communities around the country who raised their hand and said, can we do this here? Can you come and help us do this here? Well, we realized we had touched the nerve. So we got 4 foundations to fund us. Elena was the first one to figure out this was an idea worth trying, and thank you for that. Missouri Foundation for Health, Commonwealth Fund in New York, and California Healthcare all agreed to fund. We did 4 webinars, 90 minutes each. We made everybody go through 4 90-minute webinars. Then we did a survey to test, to really find out how strong and mature their local stakeholder coalitions were. And we had 10 that met the criterion that were worth, we thought, investing in. So we did site visits in 6 of those physically, and we did 4 more virtually after COVID came. And the communities you can see range across all time zones, from Spokane to Hartford, Connecticut. And notice that our big dot in Texas, that's for Waco. And Prosper Waco is a group that Episcopal Health has been helping for some time. And they are a very visionary, multi-sector coalition that has put together a very, I think, effective group. And Springfield, Missouri, Kansas City, Grand Junction, Cleveland, DC, Anne Arundel County, which is Annapolis, Eastern Virginia, and then Hartford, Connecticut. So 10 different communities. Here are the interventions that they're focused on. You see Waco there in red is focused on improving a behavioral crisis response system, which is essentially quite similar to what Anne Arundel is coming up with. And in both cases, what they're looking at is an overflow of people in behavioral health crisis who are, unfortunately, traditionally either being arrested or taken to an ED with a policeman basically handcuffed to the patient, waiting in the ED for 12 hours, in Anne Arundel's case, quite commonly, waiting for a psych consult, when in fact, what everybody knows is what that person needs is neither to be arrested nor go to an ED, but to go to a mental health professional and maybe a mental health facility in real time. And that's what they both are trying to do. And you see the range of interventions. They're different. Our view is every community must pick its own. If you asked each community what are the top 5 social determinant of health issues, they're all the same, but there are different rank orders and different priorities perhaps for taking them on first as opposed to later on. So to wrap up, the challenges so far, obviously COVID-19 slowed everything down, but fascinatingly to me, none of our 10 have given up. They all want to keep going. They all got the different spaces and they're in different distances from being finished, but they all definitely want to keep moving. We noticed that community size is definitely correlated with initial insurer interest. And what we mean by that is that in places like Cleveland and Kansas City, it's pretty easy to get insurers to really pay attention. But in smaller communities, there are just not enough bodies there, not enough covered lives there to engage insurers easily. So we've had some challenges in that circumstance. It's also true, and let's be clear, and I want to make it extremely clear, there are not enough healthcare savings to pay for utopia. And while it's unambiguously true that there are certain specific populations that can, if we intervene correctly upstream, you can save healthcare money. Healthcare is very wary in general, and this spans hospitals, plans, and everybody else, of always being asked to be the big contributor. They're always kind of the sugar daddy in the room, the ones that the other local CBOs often are envious of. And so they are somewhat appropriately skeptical about collaborative activities where they fear they're just going to be asked to write a check. What they like about our model, once they come to understand it typically, is it's not about their charitable contribution, it's about their business interest. Those business case calculations do require granular data, and therefore the communities have to get serious and specific about which interventions they mean so that we can begin to help everybody and they can do their own specific data calculations. And probably in many cases, you're going to need some, I'm going to put in quotes, permission from Medicaid. As Sahil talked about, there's different ways you can get that. There are at least 4 pathways we know of, but you do have to have one of those pathways in place, and Medicaid has to agree not to take the money back if you reduce savings. Same thing would be true for Medicare Advantage, by the way. I will say in both Medicaid, MCO, and Medicare Advantage rules over the last few years out of CMS, and indeed in some states, there's been way more flexibility granted than was the case even 5 years ago. So we're quite helpful about that. And finally, as I said, we believe each community needs to pick their own intervention. We're just there to be a catalyst to try to make it happen. And it's true that some interventions do have good evidence. It's also true that communities in designing their own may want to come up with a novel way of attacking a particular problem. And those novel interventions do have less evidence of impact already. So that becomes a kind of a trade-off between flexibility of intervention and strong evidence to convince people you've got a business case. So let me stop there, and I can't wait to get to the questions because I watched yesterday and I know the questions are going to be good. Thank you very much.
Thanks very much, Lynn. Thank you to all of the panelists. We are now going to open it up for the audience members to ask questions. And you can do that by raising your hand, going into the participant box, find your name, and click on it, and it should give you the option to raise your hand. If you struggle to do it that way, chat it to whoever's picking up the chats, and they will let me know that someone is asking a question. So let's give people about a half a minute, and then if not, I'm going to jump in. All right, Karen Batori, I see a hand raised.
Really interesting presentations. Thank you all for your time. I wanted to ask Dr. Nichols the question about, in his experience with those 10 communities, what if any, has been the role of county medical societies or medical communities? How have they integrated, if at all, with the work you're doing?
So great question. And I would say in general, there has not been a formal role for county medical societies. But what tends to be the case is that there are catalytic leaders, either in a hospital organization or maybe an FQ, or in some cases, local private physician clinics. So there are definitely people involved from the medical world. There's no question. None of this moves forward without that. Typically the health plans who get engaged, often the first person they'll send to the meeting or put on a one-on-one Zoom with me to talk through the business case is their CMO, like Salil. So there are plenty of physician and medical professionals involved. A lot of nurses, especially in the psych, in the behavioral health world. Nurses often are in charge of the units that deal with the intake there, and they know everything there is to know about how those systems work. But the medical societies per se have not yet been a big part of it.
Thank you.
Do we have another hand? Ah, Dr. Lakey.
Great conversation. Dr. Shaw, could you talk a little bit about pay for success versus social impact bonds? And are they the same, or are they somewhat different in the approach and the utility of them?
Absolutely. So we think about pay for success as an umbrella term that captures many different tools, social impact bond being the original and kind of classic and one of the tools. And the differentiator, a few things about social impact bonds. One, certainly the reliance on private capital to fund services, where payment to that private capital is based on measurable outcomes achieved. Typically, the organization that's paying for those outcomes is government, but not always government. They can be a health insurance company as well, or other organizations. It's typically focused on one intervention model, and shifting scale risk away from government to investors is a big component of the social impact bond. Not always exclusive, but a big component of it. Another form of a pay for success strategy, one that we're doing with our partners in the Prevention Early Intervention Division within Department of Family and Protective Services here in Texas, is an outcomes rate card, where we're taking a portfolio approach and thinking about how do we embed outcomes across a portfolio of like providers, like programs that are achieving similar concepts. So take home visiting, for example, that can have a nurse-family partnership, a HIPPY, Family Connects, all funded under one funding stream. How do we layer on outcomes to get a better sense of how organizations and programs are doing, but then more importantly, start thinking about how do we match the right target population with the right program to get back to serving the individuals most effectively and making sure we're using our dollars accountably. So those are two different pay for success projects. The second one does not use private capital, but it does layer in outcomes into the procurement and contracting process. Does that answer your question?
Yeah, no, very good. And that, I guess maybe a follow-up, we heard earlier, the challenge with the evidence related to some of these programs that a lot of people talk about them. In theory, it makes sense, but sometimes there isn't that hard data yet to do that. How much data do you need in order to get your attention and group to jump into an issue like this?
Yeah, so for social finance, we don't need a lot of data. We're really trying to think about where does an organization want to get to and where are they now and how do you meet the gap. So we're working with a lot of governments where they actually are needing better information to start even being able to measure what outcomes they care about. So we're helping them A, articulate the outcomes, and B, think about what existing data systems need to get connected or what new data is needed in order to measure those outcomes. Now, if you're looking for private investors to come in and bet on an intervention's ability to hit certain outcomes, the data will be much more important. It will be a robust set of data in order to give them confidence that there's a historical track record for that intervention to achieve the outcomes that are intended.
Can I also add to that? I think it's a great question about the level of evidence. And then Nirav, you set it up really well because you reminded us, you sort of tied who are you convincing with and where are they at with what amount of evidence you need. And I think in the end, that's really the key piece is which part, who is at the other end. And so, for example, for some of the work we do, there's a notion of just enough evidence to say it's worth investing in a program to further test and prove. That's one level of evidence. And then on the flip side, we have a sightline into what degree of evidence do we need to eventually get a payer to pay for something. And that's pretty high, at least a payer like a traditional healthcare payer, because for them, it's like it's their own pocketbook. And one of the things we've discovered is it's very different to talk about payment in theory and payment so we also have we have an accountability agreement that we use. It's kind of we call it like a modified pay for success. It's a rip-off of pay for success. It just looks a little different. But in order to get our goal is to eventually get a payer, not just to pay a little bit of a subsidy for food delivered to an older person, but to actually pay for results. And the goal is if you can better manage someone's diabetes, for example, outside the clinic, and we can deliver the results for a variety of measures, then we should be able to pay for that, and they should get paid the true value that's created. Well, to get to that level, you need a lot more, not just a lot more data, but you need data that is in tune with exactly the points that the payer is interested in, and those include the business case. They sometimes also include sort of quality measures that they're paying because they're not hitting some specific target. There's a range of sort of levers that they will put forward and say, well, get 2 of these 3, then maybe we'll talk. And so, again, depends upon the audience.
So we have a question through the chat from Will Terry at HHSC, specifically for Salil, who is not on video right now, but I know is still on the phone. So here's the question. Specifically for the remediation strategy, when looking for third-party providers for the environmental remediation, did the selection process for the remediation provider present any challenges given the novel source of the funding?